The timing of interpreting orthopedic tests matters. If you get an X-ray or an MRI in June, but don't present to a clinician until December, we don't know how much relevance or significance those tests from months ago still have. The same applies with repeated movement testing. I'll demonstrate what I mean by using an example. Say somebody has left shoulder to elbow pain, and I prescribe cervical retraction. So neck retraction throughout the day. I meet them on a Monday. I see evidence that we need to continue that testing at home, and that's my prescription. Now, say that patient on Wednesday or Thursday notices no improvement in their upper extremity symptoms and abandons cervical retraction. I don't really want patients doing that unless they notice that the evidence suggests from doing this one exercise throughout the day that they're getting worse. In that case, I will ask them to abandon the movement. But if there's no response or no change yet, I don't want people to abandon the test because I want to interpret the testing appropriately, timing-wise. So for this patient, if they abandon the cervical retraction on Thursday and I don't see them again until Monday, in that intervening time, it's likely that any mechanical signal or any strength signal or nerve tension sign, anything that had changed by doing cervical retraction throughout the day for 3 days, will likely revert to what it was normally without that continued retraction stimulus. So if someone's doing retraction, for example, and they're gaining neck extension the more that they do it, but then they abandon it, by the time I see them on Monday, that extension that may have been improved temporarily has gone back to where it was before. And that matters because if there's a positive mechanical change, say in the sagittal plane, but the patient's symptom is not better, when I reassess that patient, taking, again, a verbal history, taking the baselines, and then starting on the testing, I'm likely going to stay in the sagittal plane. I'm also very likely to stay with my first investigation in the retraction arena. For example, if I see mechanical improvements, I'm likely going to look at adding more force to retraction, maybe adding a sustained component to the retraction, maybe changing the load of retraction, doing it in prone or supine, for example. I will definitely make sure that it's not the case that we have the exact right motion, but other lifestyle factors like posture and protrusion are offsetting all the benefits of doing retraction on a repeated basis. But in a different example, let's say the patient was doing the retraction and was starting to lose left side bend, so lose side bending ability toward the side of symptoms. Now, again, if we lose that signal, if we lose that sign in those 4 days or so without doing it, I'm not going to pick up on that. But if I can perceive it, if the testing continues until I see the patient and I start to notice, we're losing lateral movement in the neck, I don't like this, I'm not going to likely stick with retraction at all. I'm probably not going to look at retraction extension or flexion, although flexion could be an option. It's just not something we normally see that patients with neck problems, with upper extremity complaints need something forward. So in this case, I'm likely going to be looking at a lateral movement next, maybe looking at left side bend, maybe looking at left rotation. These are not hard and fast rules because just like on the evaluation, on follow-up appointments for these types of patients, which are most types of patients, I'm going to be taking the verbal history, taking the baselines, and deciding what to do in the testing portion. But the point is, if someone's mechanical changes are not perceived, if the sign changes are not perceived by me, then we've lost that data from what that test provided. Doing cervical retraction at home, the question we're answering at its core is not, does this make your arm better? It's more, what happens? And that can be kind of a hard understanding for people because yes, they think of a clinician like me as trying to make them better, and that's ultimately, of course, my goal, but you can't make something better until you understand it. So if that cervical neck retraction changes signs for better or for worse, that tells me where to go next. And they can be very different courses of action based on how the mechanics change in terms of range of motion, strength, nerve tension, and other things. It's not all symptoms. And say retraction is absolutely the right motion for this patient, but we're offsetting it with different postures, or we just need more time. That's also a possibility because signs could change positively before symptoms change, especially if it's a patient that's had long-standing or persistent symptoms for months or years in this hypothetical example in the upper extremity. So I try to tell this to my patients, or I do tell this to my patients, to only abandon the repeated movement test if symptoms are obviously worse. Not centralizing, that's a positive response. So I want them to understand what is worse and what is not worse. But I need that data mechanically to help me know where to go next. So I don't want people abandoning a test because then we've lost really crucial data that helps us with our clinical decision making and helps us get the outcomes we want sooner.